Case number 3 is a 58-year-old male who actually presented with angina class 3, SAQ of 42, had controlled risk factors of hypertension, hyperlipidemia, and a former smoker. And other means echo had shown he had a 60% EF, but had significant positive stress test with inferior ischemia. Good medical therapy, and cardiac cath was done 323, which actually showed 3 vessel disease of the LAD, circumflex, and RCA. If I can show the pictures, we're going to show that. And today the plan is for a LAD diagonal bifurcation stenting. So this is how you can see is right coronary artery, LAD diagonal, which is a 111 bifurcation, and the circumflex, which was distal circumflex about 80%, and there was significant OM disease also. So this proximal LAD diagonal and 3 vessel disease, non-diabetic syntax, which was just about 21. So we proceeded with the PCI after discussion with the patient and the physician, since it is appropriate here. And that's where we are. I'm going to show you the angiogram.
Before you go, yeah, show us the angiogram, because obviously you treated the right coronary and now you're back for the.
Yes.
Okay. So, and also very important from the diagnostic cath, it looked to me that the ostial LAD might also be involved, but let's just see what you got.
So EF is normal. EDP was normal today. Patient is getting enough hydration. This is the right coronary artery. And this is the circumflex that was taken care at that time. And today we are for the LAD diagonal.
Yeah, but you see that
you are absolutely right, yeah, that it comes up to the ostium.
Yeah, comes to the ostium of that, and there's that ramus as well. Almost makes me feel like, I mean, it looks like your stent in the circumflex just misses the ostium, or didn't go all the way to the ostium of circ, or just short of it. But anyway, this is the case, guys, and we've got the fantastic panel. LV function, from what you showed us, was normal. So I'm not seeing any impellas in there. Would anyone be using this support in a case like this? We don't even have to talk about it. I think we can move forward, because would this patient be in PROTECT 4, Dr. Stone?
The ejection fraction has to be less than 40%.
Less than 40%.
So I don't think so.
That's right. Okay, great. So let's talk about technique. Let's start with Dr. Lasala. What do you think here? I mean, it's not that simple, I don't think, but maybe Dr. Kinney will make it quite simple. You have to keep pressing on the button as you speak.
Keep pressing. Okay,
Yeah.
you got it.
You got it.
Yeah, I think that, I mean, the plan was that they've already outlined there's a mini crush, which is pretty reasonable. You're going to wire. Doesn't need any modification. Looks like there's a little bit of calcium in there. We'd probably like to try to IVUS the LED, not only to determine the calcification, the extent, the circumferential amount, but also to try to help label us exactly where the ostium is of the LED, so that we don't try to encroach on the left main. So the biggest features here, I think, are not so much getting the diagonal and the LED bifurcation, but making sure we don't mess up the other bifurcation.
So absolutely imaging. Would anyone do this without imaging? Nitin, I don't know how much imaging you're using, but I'm told maybe not as much as we all would like you to.
Well, I mean, hold it, yeah. It's a lot more than 2 years ago. No, I would, and for another reason, that the distal left main angiographically seems relatively free of disease, but it's really important to understand how much plaque is there. It may change your strategy in terms of stenting across, et cetera. But, I think that, otherwise a two-stent strategy with the diag seems appropriate. And again, I don't think there'd be, I know Dr. Stone and I go back and forth. I mean, everything you do, you have to consider potential risks, and placing imaging catheters and things like that in certain cases can be more challenging and add time and potential risks, but certainly not in a case like this.
I want to hear from Kate Kearney. What would be your strategy here? You see the case. start, imaging and all that? What,
Yeah, I
is
think-
it IVUS, is it OCT, is it FFO? How would you go?
I have a slight preference for IVUS and bifurcation cases just for contrast utilization, but in particular, because there's a couple of things that we might need to check. I think the ostium of the circle will be fine. I do think in cases like these where it's the osteo-LAD, if there's not clearly a landing zone and I'm depending on landing it perfectly, I would just come back to the left main and make sure that we've got good apposition, because I really also don't want to have to overlap something there, and that's a higher risk of late stent failure also. And I think the ramus is small enough that you can just balloon bail that out.
And LAD diagonal, you're okay with the mini crush, or do you like the DK crush? What do you like?
Yeah, I think DK's handy and it's good for training just to get comfortable with the steps. Ultimately, they're very similar, but since you have the diag protected, reaccessing that is going to be easier. And there's not enough calcium here that I think it would make too much difference either way.
Antonio, would you do anything different than what Kate already said?
LED diagonal, I will predilate, I will do kissing, and then according to the result, make the decision. I will still consider provisional. If the diagonal has a good result, I will go with one stent.
And what about the ostium of
The
the?
osteo, I try to land real at the osteo, not in the left main.
Not in the left main. Greg, you have other thoughts?
Yeah, I mean, I agree with Antonio about provisional on the diagonal, but I'm definitely going to stent across the osteo-LAD into the left main, and then probably do a kiss with a balloon in the ramus if it gets pinched. But I find that whenever you try to land a stent right at the osteo left main, you're always short, or you're going to be in this case right across the ostium of the circumflex. So I know I'm just going to go into the left main.
Nadia, what would you do?
Yeah, I agree. I think I would probably, just seeing the angiogram so far and not seeing the imaging yet, think it looks like there's disease up to the ostium. Probably would be stenting LED back to the left main. And then this for the diagonal, I think that the approach that's described sounds like a good one. And the other thing is, if we had drug-coated balloons, this might be a consideration, in the future, using a drug-coated balloon for the diagonal.
Anyone on here would be staying with Antonio? He wants to nail the ostium. Davuri, you want to nail the ostium?
He's going to nail the osteo. They don't want it.
Well, no, tell me.
What, Chima LED?
Yeah.
Yeah. I think the imaging will tell us the size, and if there's much calcium, then maybe do IVL and then do it, but probably you don't need it.
And I think Nitin stands by you. So you got 3 people. All right. Dr. Kinney, tell us how you're going to do this.
So with imaging and without imaging, I think without imaging, I'll still nail the ostium, but we have imaging since it has been heavily requested. We will show the IVUS. And going back to the point, everything taken into equation, yes, excellent points that if you see this bifurcation, that can we do a provisional stenting? So ostium of the diag is, if you see the angle, the way the diag is taking origin, I would say the disease is still there about 60-70%. It's a large size diagonal. So every trial criteria, especially the definition criteria, was that if you have main vessel as well as side branch significant disease, and if you have Medina 111, which is 1-1, you will see that maybe some disease after the diagonal, that you should go with the upfront 2-stent strategy rather than provisional and then take care of the side branch later on. So that is where we are right now. We can show the IVUS.
Yeah. So you chose IVUS. I
second.
know you use a lot of OCT, but I guess let's see what you got. Go ahead.
Okay, I will start the pullback. Yeah, this is a mid
Sure,
LAD.
IVUS, yeah.
Here's also eccentric plaque, but I also see the half moon sign. This is a kind of myocardial bridge. Here's also eccentric plaque, some milking. Then now we come to the proximal good healthy landing zone, like for low vessel, then lumen 3.5. And now a little bit calcium, but mostly fibrous. Yeah, this is a little bit calcium. And soon come back to the eccentric fibrous plaque. And also some attenuation. This is all lipid plaque, not calcium.
Go.
Now come to the osteo-LAD. Now I see the circ from the 12 o'clock, and the distal left main is patent. So the lesion starts just at the ostium, not come to the left main.
That's right. Okay. Yes, Dr. La Sala.
Yeah, one other thing to consider is when you're looking at a provisional bifurcation like this, you're looking at it from the standpoint of the ostium, right? If it looks really bad, you're going to do an upfront 2-front strategy. Here, maybe you're thinking it's intermediate. But there's a lot of disease beyond that ostium. And if you put an IFR wire down there, it's most likely
Done.
going to be positive. So you're committed, I think, to probably fixing that because it's not going to get any better.
Yeah, no,
just by
I
protecting
think
it.
she's going to fix that. Can you please put the angio on? We saw the IVUS. Good enough. Thank you. All right. So what did you do? I think you dilated already. What was happening?
Yeah, we just dilate the LAD. I just also wanted to bring a point of this kind of diagonal. What is the wire of choice and how would you cross this
Yeah.
diagonal? So the wire of choice will be a polymer jacketed wires, whether it is field or whisper. So if you see here,
Yeah.
that was
Nice.
the wiring of the diagonal. Yes. So that's where we have dilated the LAD with the 3O balloon, and then we are going to take care of the side branch, which is a diagonal with the cutting balloon right now with a 2.5.
Good. Everyone agreed to that? How do you like that strategy so far? Dr. Colombo likes it. Everybody likes that.
It's
Go-
okay.
Yeah. Would anyone, would you just open the side branch to see what's going on, but you are planning for a full 2-stent technique here. And if you were not, you would still be using a cutting balloon, Antonio, even if you're not?
I
Okay.
think for this ostial lesion, cutting balloon is good.
Okay, good.
So going back to the other criteria is just like La Sala mentioned that if you see the diagonal, lesion is long.
Right. It's not just the osteal diagonal. I
They
saw
are not
that it
just
has-
ostium. Yeah.
Yeah, it
Okay,
has
go
some.
up here.
6-8,
10-12.
10-12.
So this is a 2.5 cutter.
It's not, is it quite in the
Go up
ostium
here.
or you need to, yeah, now there.
Yeah, now we are in the,
Yeah, now you are. Now you're,
Both.
good.
okay, down. After this, we will take, now since the lesion is long, we are going to just take care of that also.
Mm-hmm.
And after this, we'll do a, okay, now let's take an angio.
Okay. So now what? Now what would you do, Antonio, since you're doing provisional? You think now you could probably get away with a single
I'll
stent?
do kissing balloon on the LED with
Uh-huh.
the 2.5 non-compliant for the diagonal and the 3O, maybe 3.5 for the LED. And most probably going to do DCB on the diagonal and stent on the LED.
Oh, interesting. So that could be sort of a futuristic approach for us in the US. What do you think, John?
I agree. I mean, that's a great opportunity to employ that.
Stents.
We're anxious to get our hands on.
Stents.
We
3.520.
almost abandon direct
3.516.
stent, it means stenting with 2 stents. We only do for major dissections.
Kate, do you think that's going to be the future? Is that what you might think about, or you need to see clinical trial results?
No, I think
What
there's
is that?
already so much uncertainty in these bifurcation lesions, and
This
part
is
of
the
that is getting
2516.
more comfortable leaving small dissections
Diagonal
behind
first.
with DAPT, that with good flow, they will often stay open. So I think similarly, we're already trying to get away with this with the cutting balloon results
Is it
like
2.5?
that. So DCB just makes me feel more confident that maybe we're helping reduce
Great.
failure later.
Thank you. I know I'm surprised you're not putting your bifurcation app up here. What does the bifurcation app say we should be doing?
You should be playing by the side if the technique of mini crush, is it playing in the
Oh,
side?
yeah, it's over there. But how did you, but before you get to the mini crush, the anatomy is supposed to tell you what you should do, right?
No, anatomy is same. If it's 1-1-1 and significant disease with the size. Remember, if it is
Yeah, but why not
2.5 and
DK
bigger
crush?
size, we would say
Tell me why you're not doing
No.
DK crush.
it's up to the operator.
Mini
If somebody
crush, DK
says they want to
crush is the
DK crush,
same.
yes, go ahead, do DK crush. But I'm so comfortable with mini crush. Will I do DK crush? Yes, few more steps extra. So I would not
Very
want
similar.
to do that. But
I agree with that.
DK crush actually has made it to the guidelines now. So
I know.
yes, if everybody out there say I want to go DK crush, yes,
Okay, good.
nothing wrong in that.
All right. So take us through your technique here.
So we are just going with the 2.5/16 stent to the diagonal. Let's go with the side branch stent first. You see there, you park a little bit distal, and now we will go. Now the length, actually, before even the IVUS was done, we had picked a length of 20 millimeter to the LAD. And Kiski, now based on the imaging, tell us what is your length for the LAD.
From the just the osteo to the healthy landing zone is 18 by IVUS for the main
So
bunch.
20 is perfect.
Normal to normal.
Normal to normal, yeah. But the osteo is not normal, but this is
And
osteo.
goal is that we are going to nail the ostium of the LAD,
Yeah.
not stand
Yeah,
across.
IVUS technique.
So 20 is perfect. Is that a 20?
Yes.
Yeah, good.
Not stenting across, huh?
No, not her. She wants to nail the ostium. She's following you, Dr. Colombo. How do you like that?
Good.
Good.
Can I, Antonio?
Okay, now
She's
we'll bring
placing a
the.
stent on the diagonal. I would.
Yeah.
Tony, what has been your anecdotal experience with
No, no,
the high,
someday.
the high-risk restenosis area, the ostium of the side branch,
Okay,
compared
yeah.
to a DK crush or
Go.
something? What's been
Right.
what has been
It's
like?
bad.
with
It's
Where's
bad.
This is the diag.
Okay, go.
The restenosis.
Hold
The
on.
only way to avoid
Wait,
the
wait, pick
restenosis
him
of
back.
the side branch is to prevent angiographic follow-up.
How do you know you're in the, yeah.
Okay, we take a cine now. Okay.
You know, I
So
think the
tell-
important thing is, all of these discussions, whether to stent or try provisional on the side branch, whether to nail the ostium or go into the left main, we don't have hard
Okay.
data on any
No,
of
none
these
of that,
things.
of course not.
Never have hard
and
data.
right,
Okay,
and
go.
I think they're all
diag.
fine.
Yeah, go.
Yeah.
I
So
think
how did
I
you
might have a
decide?
So we are
preference,
going up
but
with the
I think,
diag.
Others
You
are
just
okay.
don't want to
14.
miss it. Can you,
Down.
Anu, can you show us what you did to nail the ostium? I mean, you just did it so fast. The world wants to learn how
Okay.
you're nailing the ostium here.
There is a traditional crash. It's an old
Yeah, it's
time
a-
crash.
Well, no, but it's mini, it's small.
I'm done.
You want to go, Carl?
Yeah. So you could see when we saw it with the angiogram, let me just show you, go back. You see that? Just one strut is in the main vessel.
Okay. Because it looks like,
So
to
it
me,
looks
it looks
okay?
a little
Some
bit
done?
like you're going
Good.
across.
To Greg's point
Good.
about not having any data, sometimes it's just a practical concern about the anatomy.
Yeah.
The closer you are to 90 degrees, the more likely you can nail the ostium. The shallower the angle, you have to have an obligatory overhang. So you might
Exactly.
as well just cover the distal part of the
Wait,
left
wait,
main.
wait.
But it was important
Okay,
to
now
do the
that-
IVUS because often the left
Yeah,
main
good,
is
right?
involved, even
Take
if
a
it
cine.
doesn't look involved angiographically.
It's involved until you prove
Okay.
otherwise.
Go up.
Going up.
So now we are at the ostium of the LAD, going up. 14.
A half in
Okay,
the
good.
left main
Done.
and half out. So you make everybody happy. Okay?
No, I think she got it
Okay,
good,
go
though.
for it.
The first strut of the stent, Greg, is right on the ostium. I think she's got it.
No, I think you'll see by the IVUS, it's
The,
like 1 or 2 millimeters. in
you
the left
already?
main.
Could be a couple of struts in, but that's okay.
But it's fine. It's fine.
Big.
Would you have,
Okay, so now we're going to recross.
Antonio, would you have wired
Yeah,
that
what's the
Ramus?
question?
Yes, I'm.
I know you'd like to wire everything.
I like to wire.
So,
Wire the circ?
no, the Ramus. You saw that Ramus?
There are no
But the Ramus
randomized
is such a
studies.
small vessel.
Yeah, well, let's see what you got.
Okay, let's take a picture here now. And then we recross, kiss.
Recross, kiss, IVUS. And then you'll tell us if you nailed the ostium. What's going on in the other room?
Ready?
Dear.
Yeah, they are ready also for you. Hold
Okay.
on. Let's take
so
a picture
just
here.
take a picture and
Actually, you
then
know
send
what
us.
we could do? Let's take a picture and image first, okay?
Okay,
Okay, good.
not bad.
Ramus, yeah, Ramus is still okay.
Yep. And I think you still need to post-dilate that ostium.
Yes,
Yeah.
we're going to do that. But I think let's
Can finish
image.
the
We have
job
to
on
make
the
sure that
diagonal,
everybody is
so you
happy
only
that we
Yes,
got
she's
the
going to
ostium.
finish the job of the
So, all you
diagonal
have is
first.
two
Yeah,
wires.
that's what she's doing.
I mean, you can see angiographically,
for the main
there's
branch.
obviously a constricted area of the ostium.
Can you
Non-compliant.
show us the fluoro so we could see how she crosses the diagonal, please? Instead
Yes,
of
yes,
the
yes.
cine?
Okay. Then I want to do the IVUS first. Let me recross, and then you want to see IVUS or kissing balloon?
I think IVUS just to see if you nailed the ostium, that's all. And then we'll go to
Good.
the other
Yeah,
room.
that's it. So we'll recross
The
and
rest
then
of
we
it,
can
you'll tell
show
us
you.
what you did and we'll see the final result. What's your wire now? Is it still a fielder?
The same fielder that was there earlier.
Okay,
It was sitting in the guide.
yeah. It's a little bit of a funny takeoff. I saw it from the beginning, but you got it. Beautiful, so beautiful. Great work. Okay,
Okay. So now what we are going to do is let's IVUS the LED, and if everything is good, you guys can move on. We are going to recross kiss.
yeah. So it's recross, kiss, final implant, final balloon dilatation, and then the final results, which we'll come back to. But let's see how you did on the placement of that LED
LED.
stent.
Okay, ready? Show it live.
Sure. This is native.
3-5.
Okay, I start the work. It's coming. Yeah, this already looks good. On the plug, but very expanded. No malposition, no dissection. Very expanded. Yeah, I'll come to the osteo.
You see the crushed diagonal stent?
Yeah.
Yeah. Yeah, area looks okay. Maybe we can do post.
Oh, for sure.
Yeah.
But we just want to see that she got the ostium.
Yep. It's
A
a
couple,
little come to
just a
the
couple of
one
struts,
strut.
but not bad. Excellent. Well
Not bad.
done.
3-5 and 3.
Dr.
3 to 5.
Kinney,
3 to 5. 3-5, 3.
please close
Okay, you can-
change the audio to
You can
Dr.
see me
Kinney's
now?
room. Okay, yes,
You left
we
us
see you.
after we did the IVUS.
Yeah,
You left us after we did the IVUS, so the balloon would not cross into the diagonal because could be of the angle also. So we did what is called as balloon anchor, where you take 1-to-1 balloon of the main vessel, go distal to the side branch. You know, you leave
Uh-huh.
it there because about 8 to 10 atmospheres, and we were able to get the balloon across. We did the kissing balloon. That was 3-5 in the LED.
Very
But what you
nice.
see in the LED right now is very important. It is the bridge that has created that look. All you do is vasodilators. Vasodilator. We gave nitro, we gave actually verapamil and nipride. And then this is what it looks like. Look at
Oh,
the LED
good.
now. Opened up.
really good. Good teaching point.
Yeah.
We saw it right after the stent implantation, a little bit of vasoconstriction. I didn't know if it was like you missed it, but here you are with the vasodilators. Really great result. And the final IVUS look good?
Yes.
Okay. Excellent.
So we are ready in
Congratulations,
room